Welcome to the June podcast of Endoscopy, the official journal of the European Society of Gastrointestinal Endoscopy and affiliated societies. Esophageal cancer is the 9th most common cancer in the UK, with 7,800 people diagnosed every year, accounting for 5% of all cancer deaths in the UK. A significant risk factor for adenocarcinoma of the esophagus is Barrett's epithelium, an acquired pre-malignant condition which affects up to 1.6% of the general population. Barrett's esophagus is found in 15 to 20% of patients having gastroscopy for symptoms of reflux. The incidence of both Barrett's esophagus and adenocarcinoma is increasing in the West. The best way of reducing mortality related to adenocarcinoma is to diagnose Barrett's neoplasia at an early stage. The use of acetic acid in the diagnosis of Barrett's neoplasia has been reported by various groups with varying success rates. All of these reports are single-center cohort studies, some with very few cases of neoplasia. These studies have used surface and vascular pattern assessments to make the diagnosis. These are very subjective criteria, and there is a lack of data on the reproducibility of these patterns. There have been no randomized controlled studies to demonstrate benefit of acetic acid over white light endoscopy. Furthermore, it is generally accepted that the differences between neoplastic and non-neoplastic patterns are subtle, and considerable training and expertise are required for competence in using them. This has generated some skepticism about the efficacy of using acetic acid and hampered widespread acceptance of this technique in the diagnosis of early neoplasia in Barrett's esophagus. Does acetic acid chromoendoscopy have any other interesting aspect that might be useful in diagnosis of Barrett's neoplasia? There is the phenomenon of the so-called acetowhitening reaction. When acetic acid is sprayed onto Barrett's mucosa, all of the mucosa turns white, acetowhitening, with a difference in whitening between neoplastic and non-neoplastic Barrett's areas. The neoplastic foci lose their white appearance, turning erythematous much sooner than non-neoplastic Barrett's areas. Longcroft-Wheaton et al. Hypothesized that the time taken for the acetowhitening reaction to disappear could be quantified to accurately distinguish between Barrett's metaplasia, dysplasia, and invasive cancer. They tested their hypothesis in their study, investigating the clinical significance of the duration of acetowhitening in the diagnosis of Barrett's neoplasia, with the aim of developing an objective criterion for defining the difference between metaplasia, dysplasia, and cancer in the setting of Barrett's esophagus. The authors report their findings in the June issue of Endoscopy in their article entitled Duration of Acetowhitening as a Novel Objective Tool for Diagnosing High-Risk Neoplasia. Here is a summary of their study. Background and study aims. Acetic acid reacts with Barrett's mucosa to produce acetowhitening, which disappears with time. The clinical significance of this is unknown. The aim of the study was to quantify the acetowhitening time in order to develop an objective tool for diagnosis of neoplasia in Barrett's esophagus. The importance of the acetowhitening reaction in Barrett's esophagus has not been studied previously. This pilot study addresses this apparent deficiency in the literature and identifies a novel but simple and universally applicable tool to identify and characterize neoplastic foci within Barrett's esophagus. Patients and methods. Prospective cohort study in a tertiary referral center enrolling patients undergoing surveillance of Barrett's metaplasia or referred with suspected neoplasia. Acetic acid 2.5% was applied to the mucosa via a spray catheter. Acetowhitening was observed and time to disappearance recorded. Targeted biopsies of any neoplasia and quadrantic 2 cm biopsies of residual Barrett's area were then taken. Histological findings were investigated in relation to duration of acetowhitening. Results. 132 patients were examined. A receiver operating characteristic curve was produced for identifying high-risk neoplasia according to acetowhitening duration. The area under the curve was 0.93, 0.89 to 0.97. Using a threshold of 142 seconds yielded a sensitivity for neoplasia of 98% and specificity of 84%. The ROC curve for mucosal neoplasia, high-grade dysplasia or intramucosal carcinoma versus deep invasive cancer showed an AUC of 0.786. A cutoff of 20 seconds yielded a sensitivity and specificity for invasive cancer of 67% and 85% respectively. Conclusion. The time to disappearance of acetowhitening can serve as a simple but very sensitive tool for the diagnosis of high-risk neoplasia in Barrett's esophagus. It can be used to distinguish mucosal neoplasia from deep invasive cancer. It compares favorably with other available techniques for lesion assessment, including trimodal imaging and confocal endomicroscopy. Although this is not an RCT but a single-center study involving 2 endoscopists, the authors suggest that it's a very effective technique and should form the basis of further studies. The development of this tool provides an objective method of diagnosing foci of neoplasia within Barrett's esophagus. The traditional assessment of surface patterns is difficult, subjective, and ideally requires optical magnification. In contrast, timing the disappearance of acetowhitening is an objective numerical measure with hard endpoints. It can be easily interpreted by any endoscopist and can be translated into clinical practice with minimal training.